and I am happy to take any questions.
Thank you very much. It's a clear presentation and very helpful, I think, for many. Personally, I must admit, I live 100 yards of meters from the Mediterranean. I still need time to adapt the diet. I still need to learn. We have many questions now for all the speakers, and I think I would like to start with the first one, and then Ken will follow up with me. I wanted to ask actually to each one of you, and it's related to the immune system of MPN patients. Are MPN patients do have an immune system? And that's, of course, has a lot of relations to the COVID, also on the risk of developing serious COVID, and also about the vaccination. If they have an impaired immune system, would they be able to develop enough immunity after receiving vaccination? And that, of course, goes also to Angela. Is there any diet which is can improve to increase the immunity or the immune system of the patient? So I think maybe we start with Professor Barbui about immune system in relation to COVID.
Yes, to my knowledge, I don't know whether there are extensive studies looking at the immune system in all MPN. What I can say is the role of some drugs for immune system. For instance, for concerning hydroxyurea, I don't see any relationship between hydroxyurea and the decline of the immune system in MPN. What is clear, it could be that ruxolitinib per se can decrease the immunological response in patients treated with ruxolitinib for its capacity to reduce the cytokines, to reduce some cells, T cells, and also NK cells that are regulators of the innate immunological response. So this is why patients who are on ruxolitinib can be more vulnerable in to be infected with the virus.
Okay, thank you. Thank you, Ruben. 1 second, Professor Barbui, I think your camera is off. If you be kind to turn your camera on so we can also see you. Thank you. Yes, Professor Ruben Mesa.
So to build on that discussion, and it's a topic I have been giving a tremendous thought to, both for MPN patients, but I also direct a cancer center. And as we try to come up with a vaccination plan, we're beginning to vaccinate our cancer patients, including MPN patients, against COVID starting this week. So this is something we have given tremendous thought to. One, it's important for people to realize that your immune system lives on a spectrum, meaning that immunocompromised is not a yes or no question. It can be a spectrum. And there are many things related to even your general health, your fitness, adequate sleep, obesity, diet, that may impact your body's own immune system. Indeed, in the US, they found that there were many individuals, really because of inadequacy of their diet. They live primarily on carbohydrates, but don't really have a lot of the micronutrients, that they were somewhat immunocompromised because of poor diet. Now, overall, I can reassure that the vast majority of MPN patients functionally do not have a significant immunocompromised state. And we all see this from our care of MPN patients, that for the most part, we don't see unanticipated infections. In ET and PV, there are exceptions, but that is the vast majority. And even in MF, Professor Barbui is correct. ruxolitinib has been associated with immunocompromised infections, but in a small percentage, probably less than 5% of individuals overall. As it relates to the vaccine question, I've had these discussions directly with vaccine and cancer experts around the world, including in the US directly with Tony Fauci and Doug Lowy, who is the deputy director of the National Cancer Institute, who also developed the HPV vaccine. So one, as it relates to MPN patients, the Pfizer and the Moderna vaccine, not all the vaccines are the same, but let's say those that are coming first are likely safe for the majority of MPN patients. The only exception is there may be a cross allergy. If people have a severe allergy to pegylated interferon, there may be a cross allergy with the vaccine. Not if you don't feel well on interferon, but if you truly had an allergic reaction, that may be a concern. Your doctor still may be able to overcome it. They may need to observe you, what have you, when you receive the vaccine, but that is one concern. The question is regarding effectiveness. And if people are significantly immunocompromised, they may have less of a response. That tends to be in the MPN world, individuals with very advanced myelofibrosis, perhaps multiple JAK inhibitors, perhaps people that have increase in blasts, but we would still advise that they receive the vaccine. At this point, even if someone has a 10% response to the vaccine, that may well be the difference between a severe COVID infection, ending up in the intensive care unit, versus not. So I would heavily encourage people, with their doctor's discussion, of course, to all consider the vaccine as appropriate.
Thank you. Ken?
As a follow-on, Dr. Mez, you mentioned the two mRNA vaccines, the Moderna and the Pfizer. What is your advice around the Oxford Astrazeneca?
I believe that the advice really will be the same. We've not had that yet in the States. I've had less kind of firsthand experience, but I have followed its development closely, as well as Professor Barbui and my good friend Claire Harrison and others have been involved with that and even participated in the trial. So I think the effectiveness is perhaps slightly less, but I would not have that defer people from taking it. Meaning, any vaccine is better than no vaccine. There's controversy in the States if you don't receive the second dose. Clearly, it is best to receive the medicine ideally as it is intended, but any vaccine is better than no vaccine.
Yes.
Okay.
Thank you.
Thank you very much. I would like to ask about alternative treatment, and that, of course, goes to Professor Mesa. I know that you have been involved personally with developing the guidelines for MPNs long time and now also. And the question is whether complementary medicine have made their way into the official guidelines for MPN, for example, the NCCN. And if not, how would we be able to reintroduce them, since when patients usually come to doctors, at least in my country, in Israel, and they ask them questions about alternative treatment or complementary, they say that, sorry, we don't know much about it. So they don't get answers that they want to have.
It's a good question. Without question, there are many complementary approaches that have been helpful for patients. The challenge is that the amount of evidence that we have around specific interventions is relatively limited. So I have patients who come up to me all the time, this diet, this approach with yoga or exercise or even a supplement, as Dr. Fleischman had mentioned, benefited them. And I have little doubt that that is in fact the case. I think there are many things that relate to our health, and they probably are more complementary than alternative. Now, alternative tends to suggest that you could use them instead of the medicines that we have. And for the large part, I view that it's probably more likely complementary, meaning you're on the best medical therapy that you should be on for protecting against blood clots, inhibiting JAK mutation, whatever that is. And these additional things are on top. They are in the guidelines in terms of, as a general group, in terms of consideration. The difficulty is that even the studies that Dr. Fleischman had mentioned are really at the very beginning of those studies being done. Likewise, the group that I lead, we have been doing trials with meditation, with yoga, and others, and again are trying to gather sufficient evidence to be able to best inform not only if you could consider them, but how. Because yoga, let's even just use that as an example, is a very vague sort of intervention. Is that weekly? Is that daily? What type of yoga? The supplements, as Dr. Fleischman mentioned, which are really medications of their own sort, it needs to be even that much more rigorous because they might have interaction with other medicines or other positives or negatives. So I think we will get there, but I do think we need to have as much rigor with the trials that we do for complementary therapies as we do for things like phlebotomy, hydria, or ruxolitinib.
Thank you.
Professor Barbui, you described a high risk of death for patients discontinuing ruxolitinib compared to continuing ruxolitinib. Have you also studied MPN patients on other treatment regimes, say Pegasus, and potentially comparing different MPN treatments against each other and their relation to mortality?
Thank you for this question, very important question. One of the problems why we did not consider the other drugs is because the other drugs were used in a limited number of patients. So it could not be assessed the association with these events. That fortunately are few events, even though 25% is important, but you cannot do any statistics if you don't have a sufficient number of events. But in our study, other additional 2-year study, we have our goal is also to describe whether something is happening also for Pegasus, for instance, for pegylated interferons, in addition to the others. But in this first study, we didn't have enough number of patients to answer your question.
Thank you.
My next question will be to Professor Ruben Mesa. It's related to the symptom burden. And I wanted to know, because many times we hear patients asking us, are the symptoms related to the disease or are the symptoms related to the treatment? So in your studies, have you been able to identify which symptoms belong to the disease itself and which one to the treatment?
Many of the symptoms are clearly related with the disease, and we could say that because of the data that we have from patients before they are on treatment. That being said, there are some well-recognized symptoms that can arise with therapy. So for example, when we did a randomized trial in untreated patients with PV and ET that Professor Barbui was on this trial as well, with hydrea versus pegylated interferon. We did additional questions related to the toxicities with interferon. And without question, there can be flu-like symptoms, fatigue, and rarely other symptoms such as thyroid-related symptoms, cold intolerance, things of that nature. So yes, medications can have a addition in terms of the symptoms, although they do tend to be slightly different symptoms that people are able to very much track. So for example, the patient successfully treated with pegylated interferon might share with me that many of their MPN symptoms improved. I have much less itching, I have less night sweats, I have less headaches or migraines, but I still have some flu-like symptoms one day after the injection every time I receive it. So it's probably a bit of both, but the majority of symptoms really are disease related.
Yes. In the last, if I may, in the last days, we published a paper on interferon in polycythemia vera, comparing interferon versus phlebotomy in low-risk polycythemia vera. And I have to say that interferon was able to reduce a great part of the symptoms seen with only phlebotomy. So even though, as Ruben said, interferon can be associated with some symptoms, but overall the symptoms are inferior in terms of the numbers as compared with the phlebotomy alone. So you have a reduction of the symptoms during treatment also with interferon.
Okay, thank you, both. Ken?
Thank you. I obviously have a personal interest in Pegasus. Is there any, in your study, Professor Barbui, did you, even if there was not enough numbers, did you get any sort of sense that interferon provided some benefit for patients within the COVID?
Yes. During my trial that is still going on, we have some patients who got COVID and they were on interferon arm. My suggestion, my advice was to continue interferon during the infection, the acute infection. Nothing happens of negative in these patients.
Thank you.
I see, if I could follow up, that there's a question in the chat that maybe I'll answer, because our understanding of this has evolved as Professor Barbui and I and some other colleagues have tried to provide guidance through the American Society of Hematology website. And that's open to the public, so certainly all are welcome to look at those kind of evolving guidelines. At first, let's say in March and April, we had a concern regarding the intensity of cytoreduction for MPN patients and whether it made more sense to lighten up cytoreduction to decrease the risk. As our understanding has evolved, we have come to the realization that good control of counts is important because of the thrombotic risk that these patients experience. As you heard from Professor Barbui, arbitrarily stopping of therapies, particularly ruxolitinib, actually ended up being harmful. So in short, we have continued to try to have MPN patients be treated exactly as they should be otherwise in terms of their medications. And I too now have had many patients that have acquired COVID, but fortunately, and this is a reflection of our evolving treatment strategies and newer medicines like remdesivir, fortunately, my patients overall have done pretty well with it. Most patients recover with fairly minimal difficulties, particularly with PV and ET. And I think our management of COVID has improved dramatically. Now, clearly at the expense of tremendous difficulties. Many of the lessons learned by really the heroic efforts of colleagues of Dr. Barbui and himself at huge European hospitals like Papa Giovanni 2030 and others really helped to inform all sorts of strategies for dealing with very sick patients that have made a difference. But in our institution, where we lead for a region of 5 million people, the mortality is less than 1% for the severely affected with COVID. But that has been because of all that has been learned up to this point.
Okay.
Yes,
Thank you.
I agree. I agree.
Okay. There's one question here on the chat is to discover the biological causes behind MPNs, do you think it may be useful to build an international registry to collect clinical data in order to analyze the correlation with artificial intelligence techniques? I'm quite sure something is being done in this direction, so we'll be happy to hear.
Yes.
Please, Tiziano.
No. I think this is a great question. It would be ideally to do a study like this, provided this study should be academic study. So we should collect this. It could be great to have at least two registries, one in the States and the other in the Europe. But we have to think about that because we have to solve many problems before getting into this general problem. The artificial intelligence is a great word, but it's difficult to do a study that could make sense.
Okay.
I strongly agree that one, such cooperation I think can be incredibly helpful. Without question, one leads very large numbers of patients and a very significant amount of data to understand several of these parts as it relates to acquiring an MPN. Something we've not discussed at this meeting, I'm not sure whether it was brought up on the first day, was at this year's American Society of Hematology meeting, we continue to learn more that some of the predisposition to developing an MPN might even be present at birth, and that things happen while we age that then lead to the triggering of an MPN in one patient versus the other patient that does not acquire an MPN. So how much of that is environmental? How much of that are things that might be reversible, such as nutrition, obesity, smoking, what have you, or environmental exposures such as toxins in water or other things? We don't know. And those are the sorts of things where to manage that sort of what we call in our world big data, which is enormous data streams. I think that that's where those sorts of things can be very helpful because in relatively small groups of patients, 500, 1,000, maybe a few thousand between a few centers, that still probably is way too little to identify some of these other drivers of disease development or progression.
Yes, we are doing something about that in Europe. In Europe, we have an organization that is called Harmony Platform. Harmony Platform is collecting big data on hematological malignancies. They have so far collected 1,000 of patients with acute leukemia, multiple myeloma, and other diseases. I am in charge to collect data on MPN, and we started with MPN with COVID. All this data will be collected in the platform, in the Harmony platform. This is why it would be necessary to have a single registry, say, to collect this data. But it is not so easy to do that for many, many reasons.
Okay.
I'd like to thank all of our speakers. Thank you to Dr. Mesa and Professor Barbui. It's been a wonderful exploration of ideas. Thank you, and Dr. Fleischman for her presentation. And we're now going into a break. Thank you very much.
Thank you.
Bye-bye. Take
Thank
care.
you all again.
Bye-bye.
We'll meet at 5 o'clock. In 20 minutes, we'll meet here at 5 o'clock. Thank you.
Okay. Have a nice Sunday.
Bye-bye.
Bye.
You too all. Thank you.